Hello, everybody. Welcome back to another episode of Mondays with Moshe. This is Moshe Norman out of Lakewood, New Jersey, and finally excited to announce something that's really been long overdue, which is our continuing ed credit offer. And now, for those of you who are interested, for those of you who are not social workers in New Jersey, because the New Jersey board makes this really difficult for us to provide credits, but for those of you from other disciplines in New Jersey, such as psychologists and others, mental health counselors, marriage and family therapists, and for all the rest of you, including social workers outside of New Jersey, you can all go to the link that's sent out on the Mondays with Moshe email, which is corewellceu.com/Monday, and sign up and subscribe for CEUs. I do believe that we are going to have an option of obtaining CEUs for listening to the recording. Also, I know that in some states like New York, there's a limit to how many CEUs you are allowed to have that are recorded and not live, but I believe in places like New Jersey and some other states, you can actually have all of your CEUs done with a recording. So if you enjoy this Zoom call tonight and have not signed up for CEUs and would like to, you're more than welcome to go to corewellceu.com/Monday and purchase the CEU option and then take the quiz so that you can obtain the CEU. So we're really excited for this new development on our show, and we hope that 3 to 4 weeks or something like that, we'll be able to do it, or 2 out of 4 weeks, or maybe we'll grow and do something more than that. But it's nice to see all of the returned faces and names. For those of you who can turn on your recording, your video, that's great. We like to see as many people as we can. For those of you who cannot, we understand that too. And of course, I'm sure you all know by now that if you have a question, please hit the reactions tab on the bottom right of your screen, raise your hand, and we'll call on you. Tonight, we are honored to feature Dr. Martha Stark of Boston, Massachusetts. Dr. Stark is a professor at Harvard University. Not sure if any of you ever heard of that place, but it's somewhere out there near Boston. And for those of you who have heard of it, good for you. For those of you who've attended, I'm going to stand up to my full height for those Harvard graduates. But anyway,
go Celtics, if I could be so bold.
Hey, wait, you didn't ask permission for that before. Okay, so Dr. Stark, Martha, has written a book that I was introduced to about 10 years ago. I'm embarrassed to say, the bad news is that I'm only up to page 19 of the book. The good news is that it's my third time reading it. But the name of the book is called Working with Resistance. It is an absolutely phenomenal book. For those of you who know me well or have been on the show know I'm not a big reader. I like to learn, by watching visual things and not by reading. But I must say that this is one of the few books, besides the book from Rollo May and a couple of others, that have really enhanced my practice. And I encourage you to purchase this book and read it. Or for those of you who do audio books or whatever it is, it's really special. The learning experience from this book is really, really phenomenal. And Martha, I appreciate that you wrote the book and that you sent it out and let people enjoy it. And now I'm even more excited to have you on live. That book was written like 30 years ago or something like that, 1994, I believe, right? Amazing. So thank you, and it's really, really an honor to have you on. Can you just give us 2 or 3 minutes? Tell us who you are, and how you got to this place where resistance sort of became something of extreme interest, and how you came to where you came to.
Well, first of all, I want to say I'm absolutely delighted to be here. Thank you so much for having me. And can people hear me okay? I hope so.
Yeah.
So I had wanted to be a mathematician, actually, majored in math at Harvard, and then decided that it was just a little bit, I loved the theory, but it wasn't people oriented enough. So I sort of partway through college decided to go pre-med and decided that I would then be a psychoanalyst ultimately, so that I could be more people oriented, well, psychiatrist and then psychoanalytic training. So I could be more people oriented, and then the analytic part so that I could also still have my passion for theory. So anyway, so I went on to do adult training in psychiatry, and then I became got child training as well. And then I got my psychoanalytic training at the Boston Psychoanalytic, which was then and still is to some extent somewhat conservative. But I then kind of went on to, and I started writing my books. And the reason I got into resistance originally is at the Boston Psychoanalytic, their teacher, someone who was going to be teaching the candidates, uh, you know, couldn't do it at the last minute. So I remember the president called me up of the institute, called up and said, "Can you teach the course on working with resistance?" And I said, "Oh, absolutely." Meanwhile, I wasn't entirely sure what resistance was. This was back in the early 90s. So I panicked a little bit. I called my dear friend Lynn and I said, "Lynn, what exactly is resistance?" So she explained a little bit to me, and then I decided to take it on. So I then wrote 2 books, Working with Resistance, and I got that done for Jason Aronson, who's been a dear friend of mine. He now has published all 9 of my books, and it was about to be released, and then he said, "Well, Martha, before we release it, I'd like you to write a primer on working with resistance also. And then we'll release both of them at once." Well, that's a little anticlimactic. But so anyway, I had to write a whole nother book, a primer on working with resistance. And then I wrote both. And those were released in 1994. And later I wrote Modes of Therapeutic Action, which was selected as Book of the Year. And I'll be talking a little bit about those 3, and actually now 4 modes of therapeutic action and 4 different kinds of resistance. And then I went on to write other books as well. I do a lot of teaching and writing, and I have a very large caseload, although I'm now trying to cut back a little bit so that I can finally have more time for my writing and my thinking and my conceptualizing and my presenting.
And are you practicing psychiatry or psychoanalysis or both?
At this point, I'm not even quite sure what psychiatry is. I do some prescribing of medication, but in all honesty, I'm not that good at it. So I know how to do the basic easy stuff. But so if that's psychiatry, then I do
You mean
that.
so you know how to prescribe Tums? Is that what you mean?
There you go.
Okay.
There you go.
All right.
Right. And
Okay.
so, yeah.
So let's jump in and talk a little bit about resistance. Classically, somebody says my client is resistant. So on a very simplistic level, you think of a 12-year-old or tween or teen, as they call them, coming into therapy and saying, "I don't care, I don't know, I don't want, I don't no, I like beating up my siblings," and that would that in our mind in the most primitive form that would seem what we would term resistance. But obviously, resistance is much more sophisticated than that. And I'd venture to say, and correct me if I'm wrong, that there's probably forms of resistance that can actually go by quite unnoticed, where a client appears quite motivated, but in reality is very resistant. And that could be confusing for the therapist, and it could make the therapist work really hard, very too hard. So could you define and give us some anecdotes of what resistance really, when we talk about resistance, what are referring to? And frankly, are there any clients who are not resistant?
Thank you. That's a great question. Yeah. So people will often think that resistance is a relational event, so that somebody is resistant in relation to the parent or in relation to the therapist. But as I conceptualize it, resistance is more an internal matter. And so I start my training more conservative, as I mentioned. So in the 70s, I was thinking more in terms of what I call the interpretive perspective of classical psychoanalysis. Then in the 80s, I was also exposed to self-psychology and other deficit models. And I came to call that the corrective provision model of self-psychology. So I ultimately, by the way, where I'm taking us to is highlighting the psychodynamic synergy paradigm that I have been working on now over the course of 40 years. So my model one, the interpretive perspective of classical psychoanalysis, which is fundamentally about resistance, those counter forces, those defensive counter forces that get in the way of these forces pressing yes. So these id forces pressing yes, and these defensive resistant counter forces protesting no, creating thereby structural conflict or neurotic conflict. The
Yes.
person internally being jammed out about being able to harness this energy of their id, which for now is anxiety provoking, but ultimately, once it's tamed and modified, will provide the propulsive fuel for the patient's advancement.
Right.
The ego, initially inexperienced and undeveloped, will be made anxious by the threatened breakthrough of these id forces. The ego, made anxious, mobilizes a defense, again, creating thereby an internal or neurotic or intrapsychic conflict. And our goal in model one, but I'm going to be telling you about models 2, 3, and 4, will be to tame the id and its dysregulated energies so that they can be harnessed and channeled into more constructive channels, and to strengthen the ego so that it will be less anxious and less afraid of the threatened breakthrough of these now tamer id forces. So Freud's metaphor of the horse and rider is very apt here. So the horse, initially untamed and dysregulated, and the rider, inexperienced and undeveloped. So the two are in conflict, said Freud. And the rider is sort of pulling in on the reins to put a lid on things. You've got the id forces, ego counter forces, and the acceleration brake and pulling in, tightening the reins. As a result of working through the patient's resistance, and we'll be saying more about that, but this is big picture overview. As a result of working through the patient's resistance, the defenses mobilized by the ego, ultimately the ego, now stronger, the id now more tamed, they will be able to evolve from conflict to collaboration. And the horse now tamed, the rider now strengthened, they will now be able to work in concert harmoniously to drive off into the sunset. And the
Okay.
goal in model one is that.
Okay, so I think I pretty much followed what you said, but I'm not sure that everybody did. And
Okay.
I'm wondering if you would be able to break this down in more either practical or
Accessible. Yes.
anecdotal, accessible terms. I think that the way you begin your book with the repetition compulsion and understanding how let's first talk about how the defense mechanism, what a defense mechanism looks like, and how it evolves, and then perhaps we can go into the next stage that you were just discussing.
All right. So there are forces within us that are ultimately growth promoting, like we know we need to have a healthy lifestyle. We know we need to drop those extra pounds. We know we need to finish our dissertation. We know we need to get ourselves out in the world. So we have healthy forces. I'm going to call those this id forces for now, but they're anxiety provoking. They're untamed, they're dysregulated, and they make us, the ego, anxious. And so we mobilize a defense that interferes with actualization of these forces.
So what would be a classic, a classic situation or circumstance where there's a drive, okay, and that drive needs, creates anxiety within us.
I know that I need to lose the weight. I've got these extra 30 pounds on me. But the thought of restricting my appetite, it's the only thing that I enjoy, quite frankly, eating, is just, and also, quite frankly, when I was younger, I was sexually abused by my uncle. And so I'm coming to realize, put the extra pounds on to protect myself. So I, quite frankly, I know I got to lose the weight, but it just gets a little bit scary for me. And I don't want to have to give up the food because that's the one thing that gives me comfort. So right there is a conflict.
Yes.
I do know that. So I do know that in order to lose the weight, one, that I should, and in order to lose the weight, that I should go on to, say, an intermittent fasting diet again. But I just don't know that I can deprive myself in that way. Here's the defense. I don't want to have to give up the one thing that gives me pleasure. So here's the conflict, the resistance that gets in the way of my doing that which I know I should do.
So essentially, when we refer to the resistance, we're referring to what conflicts the stated desire.
Yes, that's good. That's well said. That's beautifully said. Right.
And
It
that's
gets
when
in the way.
that's when patients come to therapy. When they
Yes,
say, I
they're
know
jammed
that
up.
there's something that I want,
Yep.
I know that there's something that I need, and I can't access it, or I can't
Right.
accomplish it.
I can't actualize it. I can't go
I can't
get there.
actualize it.
Right. And exactly, that's exactly right. Because there's the ego somehow, we talk about analysis of the id content, gaining access to it, and we want to do that, but we also want to understand the nature of the defenses, the resistances that get in the way of our being able to harness that energy. So something about that makes us very anxious, and we need to understand what gets in the way of our being able to harness our energies. I want to finish my dissertation, and I need to do that. I have only another year to get my dissertation done, and then I'm kicked out of the program. But made anxious, my ego mobilizes a defense and says, and I sit down to try to write, but I get sleepy, or I just can't, and I start to watch TV because I'm afraid that whatever it is I have to say wouldn't be good enough. Because actually, when I was a child, I felt that my parents were critical and never felt that what I was saying or doing was good enough. So that might be something that gets uncovered in the treatment, that conflict. So I'm broadening the concept of defense and resistance to include not just repression, suppression, isolation of affect, and compartmentalization, the more standard classical defenses, but rather those counter forces, defensive, resistant, that get in the way of our being able to harness these here forces that fundamentally will be providing the propulsive fuel for our being able to move forward in our lives.
Okay. So can you give an example of repetition compulsion? What does that mean? And how does that develop? And is this something that we should always be looking for when treating somebody struggling with some kind of neurosis?
So the repetition compulsion is that there are healthy aspects to it and unhealthy aspects.
Okay.
So the unhealthy aspect of a repetition compulsion is that we are ever busy recreating in the here and now what I call the old bad. So we're ever busy recreating that with which we're most familiar, and that's familial and therefore most familiar. Stephen Mitchell talked about it as that. So we're ever busy sort of just wanting to replay that, the only thing we've ever known, because to have anything different, so we're ever busy recreating the early on old bad, because to have something different would mean that things could be and could therefore have been better, which would mean that we would have to confront the reality that back then it should have been better, and we'd have to grieve that. And the repetition compulsion has to do with just unwittingly or unconsciously and compulsively repeating the only thing we've ever known. That's the unhealthy part of it.
Mm.
The healthy part, you were going to say something, but
Yeah, I mean, I'm just thinking out loud. I don't know that I was ever familiar with this idea that the problem with leaving something familiar is that we'll have to look back to the past and then confront that it could have been differently,
right.
and then we have to grieve that.
Yes.
I
It
guess
makes us
I always,
anxious. Yeah.
what's that?
It makes us anxious to experience something new
But
and good,
that's why people
because that
will create,
challenges
that's why
what
people
had
will
been.
create an ideal and dig their heels in, even though it makes no sense or things are
Yeah.
proven otherwise.
Yes. And that gets to, it'll be eventually when we talk more about my model 2 self-psychology and the role of grieving, of things that we are relentlessly hopeful and wanting to imagine that things are a certain way, and we're refusing to confront and grieve the reality of the way things were.
Okay, but can we argue that people don't want to leave what's familiar because they're anxious about what's going to confront them in the future? So if I'm familiar with something, even though I know it doesn't feel so good for me, but I kind of know, I know how this method, and it's comfortable. I'm comfortable being uncomfortable. I found my comfort in the
It's
discomfort,
familiar.
and it's
Yes.
familiar. If I do something else, I'm anxious because I haven't necessarily thought through what I might face, what threats I might face going forward.
Yes, I mean, and people talk about that as the fear of success, for example.
Okay.
Our fear, in fact, Martina Horner is the person who coined that phrase, and she lives in the building that I'm in right now, by the way. But
Oh,
anyway, so we have all sorts of things that get in the way of our envisioning possibilities for something new, better, and different. That could be any of a number of things. It means
yeah.
we have to sort of confront some of our internal demons. We have to, I mean, our fear of success.
Okay. So why would the argument be that we're afraid of confronting the past versus afraid of confronting the future?
Oh, I see. So in the repetition compulsion, why am I saying that they recreate the familiar? Because to encounter anything different would suggest that things could have been different.
Mhm.
I mean, or could be different. Well, so you're actually very brilliantly expanding the whole concept of the repetition compulsion.
Unintentionally.
Because I don't think, I don't know that Freud, by the way, or anyone has really talked about repetition compulsion. I believe but I'd be curious to hear from the audience, but has been tended to historically been a story about repeating the old bad, repeating same old, same old.
Yeah. No, I'm not disagreeing with that. My question is only, why is the assumption that the the changing the repetition, the fear of change, is because we might have to face our old baggage, versus the fear of what we might be threatened with if we would do something different in the future? Who knows what other risks and threats might come our way if we do something that we're not used to. At least,
Okay.
the way if we continue our
Okay.
pattern, at least we know what we're in for, what we're up
Okay.
against.
I mean, that's a very interesting point. I haven't myself thought of it in that way, but that's just because I was not thinking of it that way. Maybe I had a repetition compulsion growing up. And so maybe the concept is to sort of the idea of understanding it in a new, different way would made and does make me anxious a little bit. So I stick with what's familiar to me, which is what I felt I was taught and the sense I made of it. And so to experience and open myself up to looking at it in a new way is making me a little bit anxious and a little bit excited at the thought that sort
Fascinating.
of like, well,
That's
that's
a
interesting.
fascinating perspective.
Yeah, yeah, yeah. It's
Okay.
interesting.
But
Yeah.
but yeah, but I mean, it's definitely more profound to think of it the way you're describing it, and more simplistic to think
Well,
of it.
it's half profound, and what you're adding to it broadens it. Let me just say the piece of what I didn't quite yet say is
Okay.
that the healthy part of the repetition compulsion has to do with the desire to achieve belated mastery this time, for there to be a different outcome from what your feared outcome would have been, or your anticipated outcome would have been. So everything's sort of a double-edged sword. Quite frankly, I've come to
Dialectic.
appreciate talk about profound and so on. Everything's double-edged. There's good and bad about just about everything. But so your idea, yeah, I like that repetition compulsion. We repeat that with which we're most familiar, because to think of something new, good, and different for the future might be just too anxiety provoking for whatever
Yeah.
reasons. Or as I was saying, it means that the past could have been different. And that means we have to confront and grieve some painful realities that we would rather not have to. So you have broadened it in a very nice way. Thank you.
Okay, well, thanks
I
for
may
the
have to
opportunity.
go back and rewrite some of my books a little bit.
That's
I'll have
it.
to, if you see
That's
a
it.
new edition coming out, you'll know.
I'll put in some kind of forward
There you go.
or
There you
backward, or I don't know.
go. No, forward,
Okay,
forward.
forward. So
Yes.
I want to say hello, by the way, to Meryl Goldstein. Meryl Goldstein is an analyst who is watching. She's actually the one who gave me your book to
Oh,
begin
thank
with.
you,
So
Meryl.
it was obviously meaningful enough for her to share it. And Meryl, is she still there? Did she just drop out?
Yeah, I'm here. I'm here.
Oh, and Meryl, I just want to encourage you to chime in if you have any thoughts on any of these concepts. I know that these are near and dear to your heart. So please, by all means, if you want to chime in, jump right in. If you want, you could raise your hand, or if you're on now, you can just talk.
I was just thinking about the repetition compulsion also being, I think, a defense mechanism against remembering the past, right? We repeat what we don't remember, I think, or something like
that's
that.
good. Yeah, I like
Yeah.
that. And that we're destined to repeat, right? That which we don't remember. That's right. Right. Right.
So what does that mean exactly?
Well, Muriel.
I mean, I don't have it exactly formulated, but I think I was thinking of it in terms of there being a way in which repeating something or re-experiencing something, recreating it unconsciously, actually protects us from almost like in more creating a narrative in a way of a memory of something that's painful in a way that probably would lead to grief or maybe being able to let go of it or something like that. But that it's a defense against actually remembering something as being a memory of something that's already happened, that's over.
Sounds similar to what Martha was saying before. Okay.
Yeah. Yeah. But this is fascinating. Um, I appreciate this. This is very interesting because it's all about how difficult it is to think in terms of something new, different, and better, because we're so energetically entangled with, the old bad, much of it unconscious. We're not attuned to it, not aware of it, but detachment, energetic connection to what had been, our history, creating our destiny, especially if we can't really remember it. So we want to be, said Freud, and we're thinking here now, to remember it so we don't just unconsciously keep replaying it. But Moshe, you are introducing this really nice, interesting new concept that's profound.
I always wanted to ask, an analyst of your caliber, obsessive compulsive disorder. Is that a classic form of repetition compulsion? Is there perhaps a more organic or nature piece to it, or is it pretty much what would analysts classically see it as a form of safety and protection that can be untangled?
Oh, that's interesting. The longer I've been in this field, the more confused I am about just about everything, by the
Right.
way. I remember having read, and it was in a peer-reviewed journal. It wasn't quite JAMA, but maybe the New England Journal of Medicine. And this is a real story about a fellow who had terrible OCD symptoms and was just tormented by them. So he had both the obsessive ruminations and the compulsive rituals and routines. So a kind of doing and undoing, doing with the obsessional thinking, aggression in it, and an undoing with the compulsive rituals and routines. And he was miserable. So apparently he said to his mother, I just can't stand this any longer. I feel like I just have to kill myself. She unfortunately said, in essence, go ahead, which is not a good thing. So he shot himself in the brain with a gun. This is in the journal, peer-reviewed journal. And he actually survived, but he shot out the OCD part of his brain, which is interesting.
Well, that's probably because he couldn't repeat shooting himself a second time. So it was exposure response.
Oh, there you go. Oh, that's very funny.
Okay.
But so that would suggest that it's a localized part of the brain somehow. Or are these compromise formations? Freud talked about those all the time as a sort of aggressive, something that you would want to be able to express, but you sort of just obsessively ruminate about it and then compulsively kind of keep on doing it. So at the end of the day, defenses against aggression and sexuality probably. But did I answer your question?
My question was if obsessive compulsive disorder is a defense mechanism against, is a repetition compulsion or defense mechanism against something extremely uncomfortable, such as aggression or sexuality. Is that how you would see it?
Yes. And is repetition compulsion involved in that? The symptoms themselves are the obsessive symptoms, ruminative, are certainly repetitive, I see, and the compulsive rituals and routines. Well, yeah, maybe that's also, maybe OCD is yet another manifestation of the repetition compulsion.
Okay.
I had not seen it that way, but my horizons are being expanded, and I'm thinking maybe I do now see it that way. I mean, that on some level, all of the defenses, we could say, actually are an instance of the repetition compulsion. I've gone on to sort of use other concepts, the idea of old bad narratives, same old, as opposed to new good, empowering ones, and different and better. But the repetition compulsion is a big, grand defense, isn't it? The repetition compulsion itself is a big, grand defense that I guess encompasses all sorts of other things within it.
Let's take a question from Esty.
Yes.
Go ahead, Esty.
Yes.
Okay, thank you. Hi, Martha. Thank you so much.
Oh, hello there.
It's interesting because the way Moshe sees it is how I would see it, and your way is the new way for me. Yeah.
Does it make you a little anxious?
No, I think it's fascinating, and it might be really helpful actually with some of my clients.
So it must be a both and. It must be a both and, not an either or. It's a both
dialectic.
Yeah.
What I'm wondering is when you talk about the grief, it could be, and would you be saying that it could be the grief for what things could have been, but is there also maybe a level of grief that some clients might have about the way they behaved or their own
part, their own contribution? Yes. Anything, I like that. So not just faulting the object, but also shame and embarrassment, regret and guilt about their contribution to what had happened.
Yeah, like if somebody is stuck in a depression and the shame about being stuck in the depression could keep them in the depression.
Yeah, right? Yeah, that's good. That's another element. Okay. Yeah, I hadn't even thought of that. Thank you. Your name is Esty?
Esty.
Yeah, thank you. I like that.
Okay.
I like that. Wow.
So we're getting a sense of how some of these defense mechanisms are formed and how the clinician, might formulate them in his or her mind. Let's talk a little bit about the treatment of the resistance.
Oh, okay. Let's do that. But can I just elaborate on something here, please? For a moment?
Of course.
So I've mentioned that now there are actually 5, but there are 4 that I'm going to talk about in the moment. 4 different approaches. Oh dear,
I just want to show, no, that's me. I just want to show everyone the book.
Yeah. Oh, good. Okay, good.
Working with resistance.
So there are 4 different approaches. Oh, good. 4 different approaches. The first one is the interpretive perspective of classical psychoanalytic theory. The second one is the corrective provision perspective of self-psychology and other deficit theories like Michael Ballant in the area of the basic fault. The third one is the intersubjective perspective of contemporary relational theory. So people from the William Allenson White Institute and Darlene Ehrenberg and Jessica Benjamin and them folks. And then the fourth one is an existential humanistic approach to mending brokenness. So the first one tends to be a little more cognitive, and it involves interpretation, classical psychoanalytic. The second one tends to be a little more affective. These are mutually enhancing. It's not separated. And as a therapist, you can shift back and forth between and among the 4 different ones. Model 2, self-psychology, a little more about affect. And and now about grieving. So whereas model 1 is a story about becoming aware of anxiety provoking truths about yourself, like maybe what you've done early on in your life to provoke your parent, say, whatever. Model 2 is more about evolving ultimately to accepting anxiety-provoking truths about the object, about the other person, about the parent, about the therapist. Model 3 is more relational, the intersubjective perspective of contemporary relational theory. And this has to do with ultimately accepting accountability for anxiety-provoking truths about the self in relation, which is a Stone Center term, what you've played out on the stage of your life. And model 4, the existential perspective, existential humanistic approach, is a story about being able to articulate and share and expose anxiety-provoking truths about the private self. So there are these different resistances that we have to facing things about ourselves, about the limitations in the object, about what we've played out in our lives, and things about our private self. These resistances that all come into play, all of which come into play over the course of the treatment. Did any of that make sense?
Yeah, so what about these 4 components? Are you saying that in the course of treatment, you keep your eye on all 4 of these?
Yes, and it spells out care: cognitive, affective, relational, and existential. Care.
There you have it.
There you have it. You pay attention, because so sometimes in the moment, and let me just say, our goal in these 4 different models, in model 1, so is ultimately from resistance or defense to adaptation, from psychological rigidity to psychological flexibility, lifting from ACT, acceptance and commitment therapy. So the adaptations for the 4 models, those all start with the letter A, as it happens. So in model 1, it's awareness. It would be insight, but insight starts with the letter I, so we can't have that. So awareness, self-awareness, awareness. Model 2, the net result of grieving, of confronting and grieving the reality of the object's limitations, separateness, and immutability, will be acceptance. Model 3, where there's self in relation and what you're playing out, the contemporary relational perspective, and what you're playing out on the stage of your life, ultimately, the goal is for the patient to be able to hold themselves accountable. So we have awareness, acceptance, accountability. And in model 4, the existential humanistic approach, the goal is for the person, ultimately the private self, the true self, Winnicott here, to be able to be more authentic. So from relational retreat and relational absence to authentic presence. So the goals being awareness, acceptance, accountability, and authenticity or accessibility of the true self. And the resistances, all of those ultimately probably need to be sort of worked through with different patients presenting. So some people will say, well, can you just kind of put this in DSM language so we can kind of get it? And sort of like, well, it's not really the way I think, but okay. So model 1 would be more about neurotic conflictedness.
Okay.
Model 2 would be a little more about narcissistic vulnerability. Model 3, because they have to start with the letter N, so I got to get an N word here. It's sort of characterological stuff, but I'm going to call it noxious relatedness. So when you're playing out sort of weird stuff on the stage of your life. And then model 4, and think about Arnold Modell and Masood Khan and Guntrip, and who talk about the schizoid withdrawal. This would be non-relatedness. So neurotic conflictedness, narcissistic vulnerability, noxious relatedness, and non-relatedness are the defenses that need to be worked through, the resistances that need to be worked through to get to adaptation and psychological flexibility. Whew.
Well, that's teaching the whole model standing on one leg.
Yes.
Okay.
Yes. So that's the big overview, but now we can go back to what you were going to be asking about.
Okay. I don't remember what that was
I
anymore.
think more specifically.
We're going into treating the resistance.
Okay,
Right.
good. Okay.
So, I mean, I'd love to take a passage or two from your book, but I first, before, going into those anecdotes, which are very specific, and I think people could learn well from hearing specific anecdotes, let's talk a little bit about how the resistance presents itself in the therapy room and how the therapist or the clinician addresses it just on a global level. How would you describe that?
Well, I think of along the lines of from rigidity to flexibility, from defense to adaptation, from defensive reaction, same old, to adaptive response, something new, something different, from mindless reactivity to more mindful and more thoughtful responsivity, from cursing the darkness to lighting a candle. So you say something to the patient and you want to see if they made anxious, react defensively. Their ego made anxious, they react defensively, in which case we'll work with that. Or they're able to take it in their stride and adapt to it and work with it. Adaptive response. So moment by moment, with your finger ever on the pulse of the level of the patient's anxiety. I was taught way back to pay attention to the patient's anxiety, and I used to do that decades ago, and then I sort of forgot about it. And only more recently have come to appreciate how valuable it is to be keeping your eye on how the patient is either reacting defensively or responding adaptively to everything that's going on in the space between the two of you. So moment by moment, I mean, the patient says something and I'm deciding, I'm feeling my way into intuitively. I think the word, although I'm probably misusing it, is interoception. I'm attending to the cues in my body, my intuitive sense, my cognitive awareness of things as to whether or not I can afford to offer a little more challenge of the defense, or whether I need to offer more support.
Fascinating.
And,
So there are going to be times where too much challenge is going to overwhelm the client with anxiety.
it's going to be
And
too
so
much.
intuitively you say, or you don't say, but intuitively you feel now is not the time, or this circumstance that the client is describing is too defensive. And
In the moment.
if I
So
right now, so you're going to hold that. You're going to
so I'm
hold
going
that
to
for a
offer
different
more
time.
support. So I'm ever busy going back and forth on a very
So for like a classic example might be where a client is complaining about how people wronged them or somebody wronged them, and the client is clearly either in the wrong or misperceiving, but they're so heated about it, or they're so passionate about it, or they're so hurt by it, then that now to kick in and say, and challenge that or reflect on that would just be a waste of
Okay.
time. And
But what I can do, based on, let's say we've worked together and there is enough of a sort of backdrop of collaborative alliance, I might say, and now I'm going to do a Model 1 conflict statement. I might say, you do know that. Now I'm going to say something that they know. I can't cheat. I can't say something they don't know. So I can't say, it's because of you that, you're ever busy being victimized. I can't go there because they have never acknowledged or said that, but they've said a little something. So I'll say, you do know that, and I can put in qualifiers. There might be some things that you're doing that sometimes rub people a little bit the wrong way.
and you'd feel comfortable to say that even
I'm
then.
going to say that to somebody where it's going to increase their anxiety.
Mhm.
But that's the first half of my conflict statement. So I am challenging them because I need to back up and say optimal stress is what I feel advances the therapeutic process from rigidity to flexibility, from defense to
What does
adaptation.
optimal mean?
Optimal means just the right mix of challenge and support.
So, okay. So how do we communicate that? Because that's a really, really important point, that in communication, there has to always be this balance. You can't be too supportive
And you
and
can't
just
be challenging.
coddle, and you
Right.
can't be too challenging because then you feel like you're critical, right? So
Yes.
how do we balance that? Give me some examples,
Well,
verbal.
I'll do that conflict sentence in a moment. I'll get to the second half, but let me just say, Jay Greenberg, back in the 1990s was in essence saying, without empathy, therapy never starts, but without empathic failure, it never ends. By the same token, you could say without empathic failure, therapy never starts. But without empathy, it never ends. And he was talking about new good object, old bad object. But the point is the same. There needs to be both a challenging of the defense and a supporting of it. And so let me do the conflict statement for this hypothetical patient, and let's see if I get it done by the end of it. You do know that there might be times when your behavior is a little bit can put people off, comma, you don't say it, but you think it, comma, but, and now I'm going to name what I'm guessing will be their defensive reaction, which they will mobilize in order to decrease their anxiety, but I'm going to say it for them. But you find yourself feeling, God damn it, that if your wife, that if your girlfriend, that if your son, if your father weren't so goddamn, negative all the time or so critical, then it would be so much easier to sort of be in a comfortable relationship with him and just whatever.
So it's like you sandwich it. You pretty much sandwich it by putting it out there, and before the client has an opportunity to react too intensely,
To get defensive about what you've just said.
what you just said, you sandwich it, you cushion
Say
it,
for them.
you cushion it by saying it for them.
Yes.
So
And-
they can
and
sense, they can sense your support because you haven't left off with calling them out, which they experience as criticism.
Right. And
You've
not
only
only-
noticed.
not only my support, but I totally get it. But that they just feel that if their wife weren't so goddamn blah, 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 then they wouldn't blah, 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 blah. That they, if their partner weren't so goddamn sort of nasty sometimes, then they wouldn't have to get abusive. And you name it, without judgment, with compassion, and you feel it, and they know that. But now notice what I've done with a Model 1 conflict statement. I don't just say, there are times when sometimes you can put people off a little bit. I say, I'm putting it in them because it's an internal conflict that I'm picking up on, a neurotic, intrapsychic conflict.
Meaning,
And I don't want
meaning
it
that
to
the
be an
patient
intersubjective feeling.
herself is conflicted with her behaviors.
That's right.
Is
Yes,
that what
it's
you mean?
egosyntonic and ego-dystonic.
It's essentially ego dystonic, but she
And
doesn't,
ego-syntonic because they keep doing
but
it.
she doesn't have a choice. She has to use it because how else is she going to protect herself?
Repetition compulsion, and she feels she needs to.
Okay, so I think I'm getting this. So I need to be nasty or to be aggressive, because if I'm not aggressive,
My wife is just going to be
nothing bad's going to happen.
being nasty.
And on the other hand, I wish I didn't have to be aggressive,
Right.
whether that meant that I wish I wasn't put in this position, or that means that I wish I knew a more adaptive way
Ways to
address
deal
the
with her being so
situation.
nasty. Right.
Right.
So it opens up the field by first challenging them with what they really do know. You can almost always find something that the patient who does come to you week after week, find something that they have told you as being an observing ego, reflecting ego. They are aware that, and you put in enough qualifiers. You do know that technically, comma, but, and now we name it for them. So we challenge the defense and then we support the defense. The goal being ultimately to create some kind of dissonance between the two, the adaptive capacity to know and the defensive need to deny knowing.
Now, how does that address the resistance?
Okay.
Explain to me how that's
So it's the
addressed.
defense or the resistance that we are actually optimally stressing by challenging and then supporting. The net result of which is optimal stress of a defense to which they're ambivalently attached. It both serves them and it costs them. And part of Model 1, increasing awareness about anxiety-provoking truths about the self and their
Okay.
internal landscape, we're getting them ever more aware of both the cost and the benefit. And we're
Okay,
trying to
so let me see if I understand that.
Yeah.
Okay, now you're speaking quickly. Now let me see if I got that. So we're increasing the awareness of the client's both the client's off-putting behavior, but also the conflict itself that they're in,
their
okay.
investment in doing it. Yes.
their investment in doing it, and the
Yeah.
conflict that it serves them.
Perfect. Yes.
And we're doing that in a form that's extremely supportive and also observes the maladaptive behavior. So
Yes.
it enables a process in which the client can hear it and ingest it.
Yes.
And then we make it palatable
Metabolize it. Mhm.
by not seeing it as a good thing or a bad thing,
Right.
only seeing it as for what it is, how it's
Right.
adaptive and maladaptive at the same
Calling it
time.
like it is. Like I sit there and I'm like, I don't even begin to be thinking pathological. I'm highlighting what I know based on what they've just told me. They really do know. And then so resonating with it, it's not even like, well, now I'm going to support you. It's sort of like, I understand exactly what their investment is in it.
Yeah. So
It's like a form of mirroring, really.
I'm sorry, what?
It's a form of mirroring.
Of
Mirroring. You're
Oh,
mirroring
mirroring,
back to the
yes,
client.
yes, Dr.
what their
Goldstein, yes,
experience, mirroring what their experience is, but
yes,
in a
it
very
is.
comprehensive, because it's including everything. It's all
It
inclusive.
is. It's actually a big, major form of mirroring their state of internal conflictedness.
Right, because you're not adding in your own perspective. You're really mirroring their own internal conflict for back
Thank
to
you for
them.
adding that piece, right?
Mhm.
I am decentering, Stollerow used to say this way back, I'm decentering from my own subjectivity, my own experience, and I'm joining alongside of them and taking on their experience as if it were my own, though it doesn't actually become my own, but as if it were. So I'm giving voice to what I can feel and understand is the conflict within them. And
Now-
they can feel in a big mirroring way. Thank you, Mirror. Thank you. That's right. Exactly. And it's fun to do. Like I do it all the time.
Yeah.
I'm not busy thinking, well, I'm going to do model 1 now. I can feel that. I mean, most people
Well,
are
it resonates with them it resonates with the
resonates
clients
with them.
very deeply, because that's
Very deeply.
exactly what their experience is. And what's happening often is that they refuse to acknowledge the compulsion to do it. They only, and this is what we were talking about before the show, right? They refuse to acknowledge the compulsion to do it, and the need to do it, and put that down and criticize it, and only acknowledge the need that they have to stop doing the maladaptive behavior.
Oh yeah, right.
What you're doing is you're helping them to acknowledge the necessity and the value of doing the maladaptive
How it
behavior,
works for
which
them.
in a way that's very soothing.
Yes, yes. And I actually have, I think I put it in my book, or maybe I came to it later, but I have this little, call it a limerick for the moment. As long as, so we offer the optimally stressful interventions that optimally stress the defense or the resistance, i.e. both challenge and support, so that by the time you're done, you've increased their anxiety and then decreased it, so they can then associate to either side. So my little limerick goes as follows. As long as the gain, secondary gain benefit, as long as the gain is greater than the pain for them, as long as it's more ego syntonic than ego dystonic, then they will maintain the defense and remain entrenched. But as a result of these optimally stressful interventions, and I have them for all of my models, as a result of the optimally stressful interventions, ultimately our goal is to make the defense ever more ego dystonic. Once the pain, ego dystonic, becomes greater than the gain, ego syntonic, then the stress and strain, optimal stress and strain of the dissonance between pain and gain, cost and benefit, price paid and investment in, will be such that the body, the wisdom of the body, which can't tolerate disequilibrium for extended periods of time, as this dissonance gets ever greater, the stress and strain of that will prompt the body, its infinite wisdom, the wisdom of the body, to let go of or relinquish what's no longer serving them it, in favor of the more costly defense will be let go of in favor of the more beneficial, flexible adaptation. And that, in a nutshell, is what I think is the working through process of the resistance.
Yeah. So I I followed the beginning, but I didn't follow the second half. What is causing the
gain, the pain to become greater than the gain?
Yes.
Yes.
No, well, one second. What is causing the pain to become greater than the gain, the secondary gain?
Yes, and because I saw you,
Yeah.
you're changing your listing.
Yeah, that's when I started going like that. Yeah.
That's right. Yes, exactly. Your optimally stressful interventions, right? So we're not just challenging, which makes them too anxious, and nor are we just supporting, which means there's nothing then to master. Like if you're just supporting and reinforcing, there's nothing they need to master. So the mix of the optimal stress, the mix of challenge and support. So so they're beginning to realize, so I'm saying, in fact, that when you call your wife a bitch, that you're actually really, begging for trouble. But sometimes you find you just can't control how angry you feel. God damn it, just how angry you feel. You know that if you continue to do that, that ultimately you might lose her. Do they know that? Yes, you can only say it if you've been back and forth, all these cycles of disruption, repair. So they are sort of getting it that this is their repetition compulsion or their compulsive reenactment, which is when you play it out on the stage of your life. And so you can become ever more aggressive, if you will, or to the point in the first part of your sentence. And you do know that ultimately you may end up losing it all unless you get that temper of yours under control, comma. And you're saying that only, you're seeing if you think you can get that said, but you find yourself thinking, wait a minute, I've been so wrong. My mother used to, my father used to, blah, 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 blah. And you and they are working together to understand all of what fuels their resistance, their defenses, their same old, their repetition compulsion, their compulsive reenactments. What is it that fuels it such that they find themselves continuing to do same old, which is becoming increasingly ego dystonic as you're ever busy challenging and supporting.
Okay, so you're just talking about how the gain is becoming more ego dystonic. So I think essentially what you're saying is we're not increasing the pain, we're decreasing the gain.
I mean, you're so brilliant, it's ridiculous. Yes, in this example, it would seem to be that we're highlighting more the pain, but the gain is, we could get to that. You
Okay.
do know that ultimately you're going to be able to
Much
have the kind
happier.
of relationship that
Yeah.
you've always dreamed of having, if indeed you can get that anger under control. But it just seems so hard. So it's
Okay.
really both. I just didn't emphasize it yet,
Okay.
but it's both.
Okay, I was wondering about that. Okay.
Yeah. Oh, good. God damn, I love your questions.
Okay, that was great. So we're getting the idea of really attaching with both aspects of the conflict, the neurotic conflict, right? Both
Yes.
the pain and the gain,
Yes.
and the language that we use to do it. Can we jump into your book? And by the way, if anybody has any questions or comments, please feel free to use the reactions tab on the bottom, raise your hand, and I will be happy to take them.
Okay.
But
Now, can I though, to highlight that what I've emphasized so far is a little more cognitive. Model 2 is more affective. Remember, care, CARE,
Mhm.
affective model 2, relational model 3, and existential model 4. I'm just going to tell you an optimally stressful intervention in model 4. Can I just tell you so you get the feel of what
Sure.
I'm talking about?
Sure.
And remember, model 4 is when there's, well, I'll say this quickly, but model 1 is structural conflict. Model 2 is structural deficit, self-psychology, structural deficit. Model 3, lifting from Stephen Mitchell, is relational conflict. And model 4 is relational deficit. So kind of a symmetry there. So schizoid withdrawal, emotional shutdown, the privacy of the self. And in model 4, we want to help the patient go from relational absence to authentic presence. Okay, so here's an optimally stressful intervention. A part of you, picking up on sort of internal family systems, so we're talking about parts, a part of you is desperate to be seen, heard, understood, recognized, comma. But another part of you is terrified of being found. Can you feel how that might be an intervention that you could offer someone who keeps the private self, the true self hidden, and has trouble exposing itself?
So the difference between this and model 1 was that this is not focusing on specific behaviors, or it's focusing more on the self.
it's less cognitive, and this is more about the private self.
I
It's
got it.
less about anxiety-provoking truths about the self, and more about anxiety-provoking truths about the private, impenetrable self, the schizoid withdrawal, emotional shutdown. So it's a slightly different focus. And I'm just going to, since I have the floor for the moment, and then please, I want to go to your next question. In model 2, so that's about grieving, because we've talked a little bit about that. So I'm going to just say in model 2, an optimally stressful intervention, and let's see how this goes. So in model 2, it's about going from relentless hope, which is a concept that I've developed, which speaks to the refusal to confront and grieve painful realities about the object of one's desire. So a refusal to grieve. Okay. And can't evolve to acceptance. All right. So here's a disillusionment statement. Also optimally stressful, because that's how we work through and get from rigidity to flexibility, from defense to adaptation. So here we go. This has 3 parts, and let's see if this can feel okay for you. You had so hoped that I would simply give you, the answers. I don't want to do that one. You had so hoped that your mother would someday acknowledge the damage she's done and apologize. That's the first of 3 parts. You had so hoped. That's pluperfect tense, past perfect. I learned that in 11th grade. I don't say you had so hoped. I don't say you hoped that. You had so hoped, to put it sort of way back. But here's the conjunction that's important. But you're beginning to realize that that's not something she does. That makes them anxious. But quite frankly, they've just told you about the last 6 encounters where the mother did not apologize. So that's hope. You had so hoped that when you went home for the holidays, that your mother, and if you could be persuasive enough and articulate enough, you'd be able to get your mother to understand just how much damage she's done and get her to apologize. But you're beginning to get it, or beginning to recognize that probably, you put in quotes, probably she's never actually going to acknowledge and apologize. And that breaks your heart. That devastates you. That enrages you. You had so hoped that. It seemed like not that unreasonable to be thinking that. You had so hoped that. But you're beginning to realize. You had so hoped that I would simply give you the answers. But you're beginning to realize, they've been in treatment now for 2 years and you don't give them the answers. But you're beginning to realize that that's not really the way it works in here. And it really upsets you. It enrages you. It upsets you. Can you see how in model 2, with these optimally stressful disillusionment statements, we're trying to facilitate their grieving? This is more affective. Model 1 was more cognitive, classical psychoanalytic. This is more affective. Model 3 is more relational, care. Model 4 is more existential. Model 1 is more about the self. Model 2 is more about the object of one's desire. Model 3 is more about the self in relation, what you play out in your life. And model 4 is about the private self, when it got to true self.
Wow.
It kind of makes sense a little bit. I want to contextualize a little.
Yes. Any questions or comments on that before we jump into?
Yeah, maybe Esty or Dr. Goldstein or anyone else.
I guess they're camera shy tonight. Okay. I'd love to jump into an example from your book. It's in, oh wait, we do have a question from Sarah. Yeah, Sarah, go ahead.
Hi, how are you? Thank you so much. It's very, very fascinating. And I'm wondering where I can read more about this, which of your books, because I know I'm only getting the surface and I want to learn more about all of what you've been saying.
Oh, thank you, Sarah. As it happens, so I've written 9 books, but so can I talk about this, right, Moshe?
Sure.
Yeah, written 9 books, but actually almost all of them are available as free ebook downloads by going to freepsychotherapiebooks.org. 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 And it's all sorts of books are available for free, including about 8 of mine. The others are available on Amazon.com as hardcover. Or my email, if I could give you my email, and you can, my email. Oh, good, thank you. Yes, freepsychotherapiebooks.org. My email, thank you, Moshe, is Martha Stark, MD, at hms.harvard.edu. And as it happens, I'm actually giving a $15 talk on Friday for an hour, Friday morning. So if anybody wants to find out about that, through the International Psychotherapy Institute, it's $15, you know. And I'm going to go over I give an 18-page reference guide to people who attend. All right, that's it, because I want to get back to this.
Thank
So
you.
thank you. Thank you, Sarah.
Okay.
Please stay in touch. All of you, please, if you want to be on my mailing list, just email me at that email that I think Moshe wrote down, and
Yeah.
I'll put you on my email list. Yeah.
Super. I'm going to take us all to chapter 2 in working with resistance and the opening of the chapter. And I think this will be a great demonstration as to how we attach to that resistance, and hopefully you could share about this. So the chapter starts off, in order to demonstrate the ways in which the concepts of conflict and resistance can be applied to the clinical situation, let us think about the following 3 situations. And these are just very, very classic, circumstances, that come up in the therapy room. Situation number 1, the patient is obviously upset, but is trying hard not to cry. So this would come up in the form of, the patient being either hurt by you or having a memory that's disturbing or something like that, and then kind of distracting themselves from crying, or saying something humorous to distract, or what my favorite one, which is to say something terrible and then say it's no big deal. Like when they say, yeah, and then I was beaten up and tied to a rock, and yeah, but it's no big deal, right? No big deal. That's situation number 1. Situation number 2, the patient knows that his therapist will not laugh at him, but finds himself fearing that the therapist might. And here's where some of my countertransference comes in. We're like, come on, you don't have enough trust in me. I've been working together for 2 years. You don't know that I'm not going to laugh at you if you say something like that, right? But that's another
Repetition compulsion.
for the patient.
Mhm.
Yeah,
Not
sure.
sure, not about you. Yeah, the
For the
patient's
patient.
repetition compulsion.
Yeah. Well,
Yes, there-
almost expecting to be laughed at.
Because that's all they've ever known. Same
That's
old,
right.
same old.
And situation number 3, the patient is upset with his therapist and knows on some level that he must eventually confront the reality of just how disappointed he really is. But he would like to think that he could get better without having to do that. So fear of confrontation, basically. Okay.
Yes, and yes, right. And not wanting to grieve, not wanting to have to grieve.
Well, when you say grieve, you're referring to
That they're upset with the therapist and
How would that-
disappointed, and they
yeah.
don't want to have to face that and grieve
yes,
it.
right.
But
And
you're right,
instead,
it'd be a
let's just
confrontation.
ignore it. Let's just ignore it.
Yeah,
Yeah.
yeah. They'd like to be able to get better without having to do that. Those are good examples. Yes.
Okay. So then you write, the first option is to come down on the side of the force that says yes, which supports the patient's health, but makes him more anxious and therefore more defensive or resistant. It's pretty much what you've been describing till now,
Yeah.
right? Where
Yeah.
it's not optimal stress, but it's
A lot of stress.
too much anxiety, overwhelming
Yeah.
anxiety.
Overwhelming anxiety.
Yeah. And so we would say, you know that you are sad in the first case. In the second case, you know that I would not laugh at you. So these are truths that the client actually knows, but saying it will overwhelm them. Okay. And in the third case, you know that eventually you'll have to face the reality of just how disappointed you are in me. So
So I've
again,
actually even helped them out a little bit by saying, you know that, as opposed to just simply, I wouldn't laugh at you.
correct.
I'm already starting to put it in them if I were to leave it at that, which I don't, because of course I go on to say more. You know
Also,
that
if you were to say, I'm not going to laugh at you, then you're not actually sitting with the client's anxiety and permitting it, right? So you're just reassuring them, which is
Right.
a lost
Which isn't going to
opportunity.
go anywhere because
It's not going to go anywhere.
and you're so not hearing them. So when you say, if you were to say to them, I'm not going to laugh at you, you're so not listening to them. They just
Correct.
said, but I'm afraid you will.
Right, right. And that's such an important point.
It
When,
is.
when the client is really anxious about something and you just scream louder, it's like saying, I'm not angry.
Yeah.
You know, I
Yeah.
feel like you are going to laugh at me. And for you to say, I'm not
But
going
I
to laugh at you,
wouldn't.
it for sure will just increase my shame or
The
confusion.
shame, exactly, and feel not understood. It's sort of like, yeah, but I'm afraid, but I think you will. I think you
Right.
will laugh at me.
Right. And the same in the case where you talk about the client constantly asking the therapist questions or
Yes.
advice,
Yeah.
right? If the therapist is going to give advice, we've done nothing.
Right.
If we can start to explore the process that for in some way the client has this need
Feels
to
the
get
need
advice,
to get the
and
advice.
so then we can get somewhere.
Right.
Okay, so you address first the ineffectiveness. Let's just call it overwhelming the client. Okay,
Yeah.
that's what did we say? The yes, right? Going to the
The
yes.
yes force. Yes.
Yes force. Okay, then you address the opposite, right? Going to the no force, which is to say you are determined not to cry. You find yourself fearing that I might laugh at you, which actually I can see to some degree as validating, but mostly just as observations, not necessarily as validating the experience, but more acknowledging or observing the experience. And I find that therapists and parents make this mistake a lot, where they observe the affect rather than describing what's behind the affect. So for me to say, you're really angry now, or you look really angry now, is not actually a validating statement, because it's just an observation. Duh. Some of the clients will say, duh, hell yeah, I'm angry, right? It's not validating the experience itself.
You know what I try to do in my mind anyway, when I say you find yourself, I'm a little bit suggesting defensive reaction. And I wasn't trying to be the most empathic that I've ever been. You find yourself fearing. So I want to kind of alert them a little bit to the fact that, yeah, you find yourself.
Except that this isn't your final statement. This is
Right.
going in the no force.
I
Okay.
know.
You know the book.
Yeah.
You wrote it. Yeah.
Yeah.
Okay. And then in the third case, right, where it's about confronting the therapist, you say in the no force would be, you would like to think that you could get better without having to deal with just how disappointed you are.
Yep, you betcha, Doc. That's what I
Okay.
want.
So if we look at the yes force, it's overwhelming the client. If we look at the no force, it's super supportive,
And nothing needs to be mastered
and
particularly.
nothing has to happen, right? So then you go into, how do we synthesize this to create a full
Both.
de-resistantized, how would we de-resistanticize the client? So go ahead. So can you share?
We want to optimally stress them so that we both challenge and support, so that by the time we're done, they have the freedom to elaborate upon one or the other side of their conflictedness, their neurotic conflictedness about whatever it is.
How is the statement, describe how the state, well, let me read one of the statements.
Yeah.
And then I'd like to really break down how this statement sort of frees up the choice of the client and liberates them on some level, because this is the crux of the intervention.
Yes, it
The
is.
way I see it, it's a part of one of the cruxes of therapy. You know that you are so basically what you say is, you take both. You take the yes force and you take no force and you put them together, and this is what it sounds like. You know that you are sad, but you are determined not to cry.
Yeah. So I am, I'm thinking about Viktor Frankl's quote that he's reputed to have written. Let's see if I can sort of get this. Between the stimulus and the response is a space. In that space is our power to choose our response. And in our response lies our growth and our freedom. And I paraphrase that as, between stimulus and what follows is a space. in that space is our power either to react defensively or to respond adaptively. Anyway, so what I'm doing is I am picking up on both their adaptive response. They do know that they are sad or upset, that this one's upset. They do know that.
Sad. This one's sad. The first
This
one
one
was
is
sad.
sad. This
Yeah.
one's sad. They do know that they're sad. But the adaptive capacity to know, they do on some level know that. But defensive need, they're trying hard not to cry. Is that right? They're determined not to cry.
Yes.
They're determined not to cry. That's the defense. And
how is that going to minimize or reduce the resistance? But in
Well,
other words, by
either-
hearing this, I'm putting myself in the client's shoes and I'm trying to feel it. How is this liberating me from my resistance?
Well, it's, of course, it's a series of things that we're going to do, but with this particular sentence, but you determine, and so like, I am not going to cry. I'm not going to cry. I'm certainly not going to cry. I'm not going to cry. I've spent too much of my lifetime crying, and no, not going to go there. No, and I have to go to work and I can't spoil my makeup. No. Or sort of like, well, yeah, okay, I'm sad. I'm sad, but I don't want to do that. I don't want to go there. I don't want to go there. So they can kind of, you have it, they have the choice to respond adaptively or to defend reactively based on what you've said. And then you take what they've said and you go, so I might say, you know that you're sad and that someday you're going to have to let yourself really feel it. But at the moment, I can put in the temporal element. At the moment, you're just feeling, no, I have too much else on my plate. I don't want to go there. I don't want to do that. No. So you go along with them based on what they've just said. You advance it. You're
Okay.
working it through by giving them a series of the attention to the level of their anxiety. You're giving them a series of these optimally stressful interventions.
Okay. I want to go through the other two, and then I'm wondering if we're experiencing it the same way. I'm trying to tune into myself, into what I feel when I'm hearing these statements, and I'm going to share with you what it feels like for me, and you'll tell me if that's your intent or it's not
Okay.
your intent. Okay.
Okay. Yes.
Let's go through the other ones first. You know that I would not laugh. You know that I would not laugh at you, but you find yourself fearing that I might.
Yeah.
So pretty much the same thing.
Yes, and there we're speaking to a distorted perception that they might
Correct.
well have of you, given that
Yes.
you really have never laughed at them and you've been
Correct.
working together for 2 years.
So that's how we know that they know that you won't laugh at them, because it must be
You never have.
must be distorted, and they also know it's distorted because it's
And
never
they also
happened.
know they're not crazy. This isn't for psychotic.
Yeah, they also know it's
More
distorted
neurotic.
because it's never happened in 2
Right.
years of treatment. Okay, and let's go to the third one. You know that eventually you'll have to face the reality of just how disappointed you are in me, but you would like to think that you could get better without having to deal with that.
Right. I'm picking up on their wish. They would wish. It's a defensive need to be able, sort of like, I would wish. I'm sorry, but I'm highlighting their adaptive capacity to recognize that is their wish.
The way that I feel, the way that I experience it, is that somebody has deeply understood my experience, and again, this is how the way I understand neurosis, or the conflict of neurosis, is that besides the conflict that I'm in, which is I need it and I can't have it, right? Whatever the neurotic conflict is, I
Yeah,
need it and I
yeah.
can't have it.
Yeah.
I need to stop it and I can't do it. There's an additional sort of cap on top of that, which is, and I hate that I can't have what I need, or I hate being this way.
Yes, it's ego dystonic for me.
And but the way I understand the therapeutic process to remove that, the way I understand the therapeutic process is that when we remove that top layer, the one that says, and I can't stand myself, or I can't accept myself for being this way, then I'm just left with a conflict, which is really okay, because we all experience anxiety. It's part of our day-to-day life. Okay. So when you say to me, I'm not going to laugh at you, and you still feel, I would not laugh at you, and you still feel whatever the statement was, you still feel afraid,
And I might, yeah.
you still feel that I might. I'm feeling like you actually are understanding my experience to such a degree that I need not feel ashamed of my experience anymore.
Right. Yes, thank you. That's the intent. I mean, because I am, when I formulate this, I mean, the way I am, period, as I sit with my people, I mean, I just so, I just don't judge. I'm just so with them and trying to understand cognitively, affectively, relationally, and existentially what their experience is. And I'm trying to put it into words. And it's not just nicey nice stuff,
Yes.
but
Okay,
highlighting.
so if we could, I want to jump right on that and say, what would you say is the real curative factor of the therapy? I mean, maybe that's a too maybe
Oh,
that
that's okay.
maybe that's a too over complex, but you know, is the curative factor the fact that the client feels connected and less ashamed? Is it
Well, yeah.
multidimensional? Is it
It is multidimensional. I mean, I think I think about my four models. The cure would be as they become ever more aware. It doesn't necessarily mean that everything's all gone. They still have a conflicted relationship with their dad, which may
Mhm.
interfere with their intimacy with their partner, but they're much more aware. Model one, cognitive awareness. Model two, they've done a lot of grieving. And whereas before they had a lot of relentless pursuit of what could never be, they're now sober, maturely accepting, and they're not ever busy sort of looking for what isn't. Model three, the relational, they do play some stuff out on the stage of their lives, but they're more accountable and they recognize self in relation. They recognize that they play some stuff out when they're extra stressed and that they're more aware of that now, which means they are much better in their relationships. They don't have noxious relatedness anymore because they're more accountable for what they every now and then find themselves playing out. And in model four, there's a part of all of us that we sort of keep hidden, the private self, the true self that's afraid to be exposed. And in model four, they can bear to be more authentically present, more accessible. So awareness, acceptance, accountability, and authenticity would be the curative factors. And we get there by way of optimally stressing the defenses, the resistances, whether it's the classical definition of resistance, whether it's relentless hope, whether it's compulsive and unwitting reenactment of unmastered early on relational traumas, or whether it's relational retreat, emotional shutdown, schizoid withdrawal. Now, just to throw something into the mix, it is true that in the last 5 years or so, I've added my fifth model that I do just want to say here. And this is for analysis paralysis, when quite frankly, the patient has awareness, acceptance, accountability, and authenticity. But quite frankly, they're stuck. They're in a rut. There's your R word. The resistances start with the letter, the defenses start with the letter R. They're in a rut, refractory inertia. And now what we want is, because it's analysis paralysis, we want there to be action. And because they've got all these other adaptations, but they're not doing anything. So action is where we really want them to lean into the edge between the present and the future. So instead of just trying to remember so they don't repeat, thank you for commenting on that, Dr. Goldstein, so they don't repeat that, yes, but we also now want them to envision possibilities for their future, possibilities that will be better and different and new good and not just the old bad. So model 5 is a quantum neuroscientific approach to analysis paralysis or refractory inertia.
okay? Okay, Elliot Kaplan, question, go ahead.
Okay. Well, first I want to thank you for coming on and a lot of interesting information and material. What I heard mostly is that, and from my own thinking, the curative factor is the joining, the ability to join the client. And I don't know if Moshe, I wrote a book on paradox psychology. So what I heard that you were doing was that you were taking the yes and the no, and you were somehow bringing that together. And I found that that was, that could be very powerful because you're acknowledging the client and at the same time, you're acknowledging both ends that they're coming in with. The other thing that I would want to throw out, I know it's the end here.
Oh, no, this is good. Go on about your paradox. I love this.
Yeah.
Love it.
In paradox,
and there's a place for that in my theory too, by the way, and I love it that you're
I'd
talking
love
about
to hear that piece because in my view of paradox, I find that the therapist is often more resistant than the client.
And more
Okay,
invested in something
meaning-
that can't be.
Well, I mean, meaning that the therapist often has an agenda
Yeah.
that that if the client doesn't meet their agenda,
The-
then
The therapist is relentless in his own right, ever busy needing and wanting the patient to do a certain something that, quite frankly, the patient isn't going to be doing.
right,
But
exactly.
isn't that repetition compulsion?
On the part of the therapist now.
Yes.
Yeah,
Right.
yeah, yeah. Which seems to be our theme tonight.
Right.
I like that. Well, Elliot, and yes, Moshe, Elliot. So yes, I have what I talk about in Model 2 with the self-psychology and all that. We can use our empathy, our understanding of where the patient's coming from. We can use that in one of two ways, either like the way we've been talking, or we can do a paradoxical intervention where we say, if I'm understanding you correctly, correct me if I have this wrong, we say to the patient, but it would seem that from what you're saying, that probably you're not actually ever really going to move forward with getting the divorce, that even though you're miserable and you go to bed every night crying and so on, stuff they've said. So if I'm understanding you correctly, that probably at this point in your life, you're just feeling so old and so tired that probably this is going to be the way it is for the rest of your life. Am I understanding you correctly? And then of course, they never get mad. What they might say, no, I can't stay with her forever. If they fight you on it, that's fine. Or they may say, yeah, I just can't do it. So am I on the right track there, Elliot?
Yeah, it's close.
I'm going to have to get your book. I like that.
Yeah, it's
And of course,
on
Jay Haley's books, of course, are wonderful.
Yeah,
Haley,
yeah.
too.
It actually explained, Erickson and
Milton Erickson. Yeah.
and Pearls, they didn't explain what was happening. In my book, I explain exactly what's happening. But the core of it really is the attachment, which you were alluding to, that when you create that attachment with the client, I see you and I see the struggle that you're going through. And the examples that you gave, you described the struggle before the client described it to you,
Yeah.
which indicated to the client, oh,
Yeah.
I'm seen.
Yeah.
They feel validated. And as
Yeah.
soon as they feel validated,
Yeah.
now they can relax.
Oh, I see.
And
I
now
see,
once they
I
can
see.
relax, now they can change.
I see. And you're saying that actually with the paradoxical intervention, in the same way, connection is at the heart of it, that you're so connected with them that you really do get it based on what they're saying, because you've let go of, you've relinquished your own investment, which Moshe was commenting on a little bit, your own investment, your own need for them to be doing a certain something for you. That's not what they're interested in. And
Right.
you're really connection-wise, really hearing and really registering. And you have to do it without any sarcasm, without any judgment, without any sort of sardonic anything, just sort
Right.
of like you really get it from what you're saying. We say it would seem that perhaps right now is not the time for you to be ending the relationship or moving on to another job, that it's just not the time. That's good. So we've backed off on our own relentless
Agenda.
pursuit of what
Yeah.
can never be.
Yeah.
That's good, Elliot. Thank you. I'm definitely going to get your book.
Okay. Thank you.
Wow.
I like that.
Okay. Well, it's 10:30, 10:29.
Oh my gosh.
I know we're just getting started, but there's always next Monday or the following
I
Monday.
just want to thank you because I have all of you here because I've got a lot of stuff to think about here and I love it. This whole thing about the repetition compulsion and what is it really and the paradoxical intervention stuff. I'm very excited about this.
And I have a feeling we'll
wonderful.
still be in touch.
Oh, I hope
as
so.
you-
I
Okay.
hope so. Thank you
Well-
all for
Well,
listening.
thank you for joining us and honoring us. And this was really enlightening and insightful and exciting and fun. And I love the energy that you brought, the positive energy. So thank you. And we're gonna log off for tonight. We're gonna stop the recording. For those of you who haven't met me yet or anything or
Oh,
want to
thank
stay.
you, Razy
Yeah.
and Robin. Oh,